Moving on to the third topic, which is for as a family physician, I think they should be really aware of which are the foreign bodies they can actually attempt to remove in their clinics, and when and which ones are they. So if you were to classify them, just tell them.
Essentially, essentially, the foreign bodies which you can remove with complete safety are the ones you can see well. As simple as that. Paint, flakes, etc. can be easily removed. Now the question is, how do you know which are easy to remove and which are not? Especially if you are not given an instrument to see them through. It's very simple. You take a torch, move it along the line, along the eye. What I don't want you to use is those new LED torches. Use the old-fashioned torches. They use rings. You will see a distortion of the ring as it moves over the surface. If the foreign body lies on the anterior surface, it causes a distortion. Easiest way to remove it without causing any risk to the eye, put in a drop of local anesthetic, put in a drop of lubricating. First the local anesthetic, prop cane is usually the best, propar cane. Then put a drop of a lubricating drop, whatever you got. Take any flat object which you got and sweep it on the eye, nothing happens. If the foreign body is on the surface, it will just come out. And that is the end of the whole story. You don't have to lever for it, you don't have to dive for it, you don't have to dig for it. Still, if you are interested in, fond of digging, then the answer is again simple. You take a 26 gauge needle. Assuming that you are using the standard 26 gauge needle, if you see that the tip of the needle there is a bevel, a little triangular bevel which is the end. You cannot exceed more than 1/3 the width of the bevel. Not the whole length of the needle. At the end of the needle there is another bevel. There are two bevels on a needle. One is a long bevel, one is a short bevel. 1/3 of the length of the bevel gives you 1/3 the width of the cornea, safe enough to enter without causing any risk. The way to do it is again simple. You go right up to the edge of the foreign body, put your edge of your needle there and just lift forwards. That dislodges the foreign body. Don't go under it and lift it. Just go to the edge, lift forward. Perfectly safe, you will not harm. So if you are stuck at a point, you want to do it, do it. If the foreign body is deep, don't play with it. If the eye is soft, don't play with it. If there is redness, don't play with it. Because these usually are perforating injuries. If the person says, my vision has gone down, don't play with it. It's not worth the headache, send them off.
Right. So the take-home messages for you all are the congenital foreign bodies, the surface ones are easily removable. Provided you have a drop of proparacaine or even maybe 2% lignocaine, 4% lignocaine, it will burn a bit but it will help. So that's what we're trying to get you all to do. And just to let you know, as Sir described, some of the disasters that can occur due to a faulty technique.
And disasters are simple. The most important disaster, of course, is perforation. Second is infection. The deeper you dive into the eye, the greater are the risks that you will produce a corneal abscess unless you have done the appropriate antibiotics. Be certain that you start antibiotics at 2-hourly interval in case you have been tempted to go around digging at no other place. You are in the village, you have to remove it, no option. Do that, but use your antibiotics. The other important thing is try and make sure the needle lies at a plane. That means supposing this is the cornea, go at a horizontal plane, but the chances of digging is not there. Don't go vertically because then you are asking for trouble. And of course, the risks are always there. If you perforate it, you are likely to produce a cataract. It's easy to occur. 26 gauge needle can penetrate fairly easily. So just be careful.
Right. One of the things that was taught to us in our postgraduate days was to take a consent before doing a foreign body removal. I remember in my first year of private practice, I had a corneal foreign body, and the minute I told my patient, I need you to sign on this piece of paper, he ran out of the clinic, called his general practitioner, called me back and said, "Boss, kya kar rahe ho yaar? Sign kya rahe ho? Nikal ke bhej do." So what sir is trying to say here is sometimes we do it because we've seen what can go wrong. When we try to remove a foreign body, if it's really deep, we successfully remove it, you can have a perforation. The patient needs further treatment, and that's the reason why we do it. So if at all one of your patients comes and tells you that this doctor is asking for a consent, there is a medico-legal reason for it. If the foreign body is in the central pupillary axis, even if it heals with a scar, we need to tell them that these things can happen. So please, if your ophthalmologist asks for a consent, he is valid to do that. So what about the safer drops, and what is the most interesting find you have seen in the foreign body in the eye?
The most interesting thing I've seen in the foreign body in the eye essentially was a fish head. But I mean, it is one of those rare ones where at the Bachimar Nagar, the person got bit and part of the head of the fish got stuck into the eyes. That was one of those very rare things. But essentially, foreign bodies, you see almost anything under the eye. And anything under the world is lodged in. The eye is unfortunately one of the most accessible organs. And equally unfortunately, when you want to see an object close, you go close to it, which brings the eyes too close to the object. So it is prone to get caught in all these disorders.
Right. So basically, a safer drop for a general practitioner would be any local antibiotic, preferably not a local steroid or a lubricating drop if you can't successfully remove it, and then forward it to the ophthalmologist.
Patch it and forward.
Yeah, patch it and forward. That's it. We're coming to a quick topic, which is a very vast topic, but it's about macular degeneration in retinal physician. How often should a person get a retinal examination as a regular patient and maybe a hypertensive or a diabetic?
That's a loaded question. Okay. Essentially, retinal examination should be part of any regular eye examination, but giving that aside, certainly all high myopes, anybody over the power of -5 should have it checked. If the person complains of flashes, presence of seeing little spots in the eye, it's a specific reason why you should go ahead and see it. Seeing rings of floaters, sudden onset of rings of floaters, or foreign bodies occurring from a particular spot in the eye, usually is an indicator of a break occurring and should lead to a detailed eye examination. And of course, with diabetic retinopathy, it's detailed examination of the retina is not mandated, it's not just optional, it is mandatory. Because if you have diabetes for a period of 10 years or so, and if your blood sugar levels are more than 180, sure as the good Lord made little babies, you have